Good evening, everyone. On behalf of IACM, I extend a warm welcome to all of you. Today is the 5th of our national online CMEs. The topic this time is hypertension. For members who are joining us for the first time, I'd like to inform them that these CMEs are held regularly on the first Thursday of every month from 8 to 9:30 p.m. The main purpose behind these CMEs is that the experience and expertise of the master teachers is available even to the remotest clinician of our country in the comfort of his home or office. Today is definitely a star-studded event. Legends of clinical medicine in India have very graciously accepted to be a part of our CME in the form of speakers, moderators, and chairpersons. I welcome them all. I feel honored and privileged in informing you that today we are blessed by the presence of stalwarts of clinical medicine in India who are our guests of honor tonight. They have been associated with IACM since its inception in 1992, that is for now around close to 30 years. It is their foresight, dedication, and hard work which has brought IACM to a stage where it is today. The guests of honor tonight are Dr. K.K. Parikh sir, Dr. M.M. Singh sir, and Dr. A.K. Gupta sir. Dr. K.K. Parikh sir, past President API, past Dean Indian College of Physicians, and is the current President of IACM. He needs no introduction at any forum. His presence alone is enough to guarantee the success of any endeavor or conference in India. It was his idea to have these CMEs, and he has been working tirelessly since day one, since we organized our first CME. He puts in a lot of effort to ensure that the most suitable topic is selected and the best speakers are given the job of deliberating on the same. I would now request Dr. K.K. Parikh sir to bless this association with his words of wisdom.
Sir, you need to unmute yourself. Parikh sir, you need to unmute
Parikh sir,
yourself.
please unmute, sir. We can't hear you.
Thank you, MP. Thank you very much for your kind words. I may inform that the efforts of MP Singh in organizing these CME programs are great, and the initiation and bringing all speakers, all stalwarts of API and other faculty members on this platform is really great appreciable. Because of his efforts, we are continuing these CME programs. So, good evening, friends. It's a great pleasure to welcome all of you on this evening of National Online CME of Indian Association of Clinical Medicine. I welcome especially our guest of honor, Dr. M.M. Singh, the founder secretary of IACM and the renowned neurophysician of the country and the person who involved in nurturing this association to bring at today's level. Dr. A.K. Gupta, past president of Indian Academy of Clinical Medicine, retired head of the Department of Medicine, SN Medical College, Agra, and the pillar of strength to IACM. Even today, he devotes so much time for IACM and takes care of all the activities. Thank you very much, both of you, sir, for sparing your valuable time. I also welcome and extend my sincere thanks to our faculty members, Dr. G.S. Wander, a well-known cardiologist of great repute and hypertension expert of the country, past president of API, who was involved in bringing out the Indian guidelines on hypertension with Professor Siddharth Shah. Professor Dr. P.C. Manoria, cardiologist of great repute, a great academician, past president of API, IACM, Hypertension Society of India, and many more associations in India. Thank you very much, sir, for sparing your valuable time. Dr. Mangesh Srivaskar, a dynamic chief editor of JAPI, past honorary secretary of API, great academician, and a very popular physician and friend. Thank you very much, dear. It is my pleasant duty to welcome our chairperson and moderators, Dr. D.P. Singh, Professor of Medicine and past chairman of API Bihar, Vice President of API Bihar, and governing body member of API and a very popular physician in Bihar. Dr. Puneet Saxena, Professor of Medicine and a very dynamic physician who organized a very successful national conference, EPICON, in Jaipur in 2022 against so many adversities. I also welcome Dr. Samarjit Banik, Vice President of IACM and a very popular physician and an active governing body member of IACM. I welcome all delegates attending today's CME program. Friends, today's CME, we have selected the topic of hypertension because in spite of increasing awareness about hypertension, coming with new molecules of hypertension, they have come in the market. A lot of things have changed, but in spite of all, the incidence of hypertension is increasing in the population, not only in India, but all over the globe. 1/3 does not know that they are suffering from hypertension. 1/3 do not know that they are suffering from hypertension, and 1/3 of the population, despite of taking blood pressure, cannot keep their blood pressure at a target level. So the control of hypertension is not very good in India. That is the reason we decided to keep a topic on hypertension, and we invited legends of medical fraternity and experts, master experts on hypertension, Dr. G.S. Wander, Dr. Mangesh Tivaskar, and Dr. Manoria, P.C. Manoria, sir. So friends, I hope we will be more wise after today's discussion, and we will translate our knowledge in our day-to-day practice to treat our patients and to increase awareness in the public so that they can take care of their blood pressure and monitor and control their blood pressure. Thank you very much. Jai Hind, IACM.
Thank you, sir, for your words of wisdom. With this, I'd like to invite our next guest of honor, Professor Dr. M.M. Singh. Sir has been Director, Professor and Head PG Department of Medicine, Medical College, Agra. He is past Chairman, Scientific Committee, API, recipient of numerous orations and awards, including Rabindranath Tagore Oration of API. Sir has been associated with IACM since day zero. He's Founder Fellow 2. He's Founder Secretary of IACM, Secretary of Constitutional Committee of IACM, and has been President of IACM. I would now request him to brief us with his words of wisdom.
Friends, Indian Association of Clinical Medicine was formed in year 1992, and the first national conference was organized in Agra in 1993. I believe for any association there are 3 stages. One is foundation, second is sustainability, and third is progress. As far as foundation is concerned, I've been associated with this association for the first decade, for first 10 years, first as a secretary for 6 years, then as a president-elect, then president, and then past president. This decade, first decade, it laid a firm foundation, and during this decade, attempt was made to make it truly national, as evident from the fact that the first 6 conferences were organized in the different states, like first in Agra in UP, second in Bihar at Patna, third in Andhra Pradesh at Hyderabad, fourth in Tamil Nadu at Chennai, fifth in Rajasthan at Kota, sixth at Punjab in Ludhiana, and then at Kolkata in West Bengal. The second stage, after the first decade, there were certain problems, few adversities, and there were challenges to continue activity in a full swing. But in the next 2 decades, the association and its activities were sustained and the conference was organized regularly. The credit for this sustainability goes to Dr. A.K. Gupta, who has nurtured it at first as secretary, then as president, and later as past president and an advisor. The end of second and beginning of third decade is witnessing a progress in the activities of Indian Association of Clinical Medicine. The conferences are being organized with good academic, scientific, and clinical material helpful to practicing clinicians as well as postgraduate students. 2022 convocation was held after 2 years due to corona epidemic and witnessed a large number of fellows who were awarded fellowship. And now, a new feather in the cap is organization of online CMEs. This is the 5th successful CME being organized under the leadership of Dr. K.K. Parikh. Number of the participants in online CMEs had been more than 100 each time. Great enthusiasm of participants, useful clinical discussion, helpful in day-to-day practice has been attraction to these CMEs. All the credit for this goes to Dr. K.K. Parikh and Dr. M.P. Singh, the convener of this online CME. All this has been possible only due to the great vision and efforts of our dynamic President Parikh. I may inform audience that Dr. Parikh has been associated with the association and with me since early days of its formation. Today is another milestone in the history of clinical medicine when 3 great stalwarts of one of the largest associations of physicians of India are participating in this national IACM CME. I welcome Dr. P.C. Manoria, Dr. G.S. Wander, and Dr. Mangesh Tewaskar on a forum of Indian Association of Clinical Medicine. Long live IC.
Thank you, sir, for your words of wisdom. We are blessed to have you with us. Our next guest of honor is Professor Dr. A.K. Gupta, sir. Sir has been former Director Professor and Head Department of Medicine, Medical College, Agra. He's been my teacher, mentor, and guide. He was the recipient of Commonwealth Fellowship in Nuclear Medicine and is one of the pioneers of nuclear medicine in India. Sir has been associated with IACM since its beginning and has been President as well as Secretary of IACM. He continues to work diligently for the upliftment of our association and takes a keen interest in all its activities, including today, even today. I will now request Professor Dr. A.K. Gupta, sir, to say a few words to our audience.
Thank you, Dr. M.P. Singh. Everything has been told by Dr. Parikh and Dr. M.M. Singh. I take privilege to tell that I had been associated right from the beginning with the association when Professor Vahal and Dr. M.C. Gupta made the association. At that time also, Professor M.M. Singh was the most active person to add the number of persons from different parts of the countries, and organizing the different CMEs. And at that time, even the annual conferences was, to the beginning, it was probably difficult to organize, but he managed to do so. He remained secretary for a number of years. After him, I took over the charge from him and I tried to nurture the association. And thereafter, as a president and then past president, and even not being association in any part of the governing body, I am attending most of the meetings, almost all the meetings organized by the IACM, and we are seeing that all the big stalwarts from the different parts of the country and the Dr. Manoria, I remember that long back he made a conference at Bhopal, and then I was selected as one of the speakers when I was very young at that time. But he called me at that time. It was in 90s, and thereafter we saw Dr. Wander taking over as API and having many conferences at Punjab, at Patiala, Amritsar, and Ludhiana, and Dr. Wander had been associated with that. Dr. Mangesh Tewaskar also had been helping us a lot in the routine of the IACM. So I now thank once again for all the participants and hand over mic to Dr. M.P. Singh for further progress of this. Thank you.
Thank you, sir. It's always a pleasure and honor to have you with us. The chairpersons for today's CME are Dr. Samarjit Banik sir and Dr. Puneet Saxena sir. Dr. Banik sir is professor and head medicine in New Jalpaiguri Medical College. He is secretary of API Siliguri and is the current vice president of IACM. Dr. Puneet Saxena sir is senior professor in unit head medicine Medical College Jaipur. He is vice chairman of Rajasthan API and a member of governing body of API National. He is also remembered as being a successful organizing secretary of the landmark Epicon 2022. The moderator for today's program is Dr. DP Singh sir. Sir is professor and head of respiratory medicine, Medical College, Bhagalpur. He's been past chairman API Bihar chapter 2013 and 14. He has been president IMA Bihar 2016 and 17 and was a member of governing body of API National continuously from 2015 to 2023. We welcome you all, sir. And with this, I would request Dr. DP Singh, sir, to take over the proceedings and start conducting the today's CME. Thank you.
Thank you, Dr. N.K. Singh, sir, and thank you, our respected President, sir, K.K. Parikh, sir, and our respected M.M. Singh, sir, our respected A.K. Gupta, sir, who are our not only guide, but also they are the we are actually followers of them. And Dr. N.K. Singh sir and Dr. K.K. Parikh sir has already done good your online IACM national CMEs, and it's a great move on the part of them and also from the IACM governing body. And now today we have a focus topic of hypertension, and our speaker, first speaker, Dr. Mangesh Tiwaskar. Dr. Mangesh Tiwaskar sir has been already introduced by our President sir, Dr. K.K. Parikh sir, but he is very much well known to all of us, and he is the Secretary General of previous Secretary General of API, National API, and also he is the Chief Editor of JAPI at present. And his topic of today's discussion is management of hypertension, Indian population guidelines. And now I hand over the mic to Dr. DP Singh sir to continue the proceedings and ask for Tiwaskar sir to start his deliberation. Thank you.
Thank you, Dr. MP Singh sir. This is a wonderful evening in which this CME on hypertension has been organized by none other than our great President of IACM, Dr. K.K. Parikh sir. And today we are going to have the deliberation from the legends of hypertension like Dr. Mangesh Tiwaskar, Dr. P.C. Manoria sir, Dr. G.S. Wanda sir. And as you know that the world population, that is more than 1 billion people suffering from hypertension. There are more than 23 million people suffering in India. And this is a very great, large number of patients are suffering from hypertension and being a silent killer, large number of this cardiovascular and other morbidity and mortality is associated with that. So first speaker is Dr. Mangesh Tiwaskar, and he is going to give us the guideline-based approach of hypertension, how we approach as a clinician, as a physician to this very important subject that is hypertension. Over to Dr. Mangesh Tiwaskar.
Good evening, friends, and good evening, my teachers, all the galaxies, and the entire team IACM, including Dr. Parikh, Dr. Singh. Thank you very much for this wonderful, wonderful opportunity, and I'm truly privileged. So before I start, a quick technical check. My screen is visible, I believe.
Yes.
Yes, sir,
Properly.
your screen is visible.
Yes, sir. Thank you very much, sir. And Dr. Parikh, I must appreciate your vision of discussing this hypertension program today, especially on the backdrop of the recently released European Hypertension Society guidelines. Friends, we know, as everybody has spoken, including our stalwarts like Dr. Wonder, Dr. PC Manoria sir, those who are here, they will surely agree that we all are aware that blood vessels are the battlegrounds for the cardiovascular events. And what impacts the most the health of the blood vessels is, of course, the uncontrolled pressure. We've been aware about this problem, but how many of you are aware that blood pressure is a real, truly accurate, measurable, as well as the predictor of the cardiovascular morbidity and mortality? It is not only accurate and reproducible, but it is a wonderful tool to even have the preventive approach as far as the cardiovascular outcomes are concerned, no matter it could be the primary outcomes or the secondary outcomes. And this is not a rocket science when we know that the moment blood pressure rises by around 20/10, the mortality as well as the morbidity related to the cardiovascular risk doubles technically with each rise of blood pressure by 20/10. But not only that, what has really enthralled me is when I realized that if you really control blood pressure by just 4 millimeters systolic, you could see how much mortality benefits, no matter it could be through stroke, it could be the end-stage renal disease, or it could be through the coronary artery event. You get amazing benefits, isn't it? So I was reviewing the fact that which intervention probably is one of the wonderful tools of achieving the best cardiovascular event reduction. And when I looked at A1C reduction, I achieve around 1.5% of probably the cardiovascular risk reduction. If I lower LDL cholesterol by 1 millimole, that is nearly 39 milligrams, I achieve around 4%. But when I lower systolic blood pressure by 4, I achieve nearly 6.5% of the cardiovascular risk reduction. So we do need hypertensionologists also for this country to manage blood pressure in this country adequately. Because as Dr. D.P. Singh has really pointed out, that this is one of the most prominent contributor to the premature deaths. 4th in the developed country and 7th in the developing country. And whenever I speak about this, I get this question from the audience that why 7th in the developing countries? We need to understand that India still is a developing country and we die with some other reasons before even people die of hypertension. And look at the second line on the slide. After the age of 55, if you're not hypertensive, you have a chance of developing hypertension in a tune of around 90% in the rest of the lifetime. And this is Framingham's data. And it has been predicted that around 1.5 billion people by the end of 2025 are likely to be, either diagnosed hypertensives or probably under the treatment of hypertension. And we all know that what is the impact of the cardiovascular risk. So when you talk about Indian subcontinent, at the backdrop of stroke, obesity, diabetes, cardiac disease, dyslipidemia, malignancies, when our country is caught up into a battle of modernization versus the economy, hypertension plays a major role as an unseen culprit. Unfortunately, it doesn't get that attention or importance. And I had an opportunity to write down an editorial in JAPI way back in 2016 when I was looking at the hypertension control in India. And this is a data from the Ministry of Family Welfare. And I could find out that the incidence that time was around 1 in 4. But then I'm going to show you some mind-boggling figures. Now, this is this year's WHO incidence of hypertension as far as the Indian population is concerned. If you are looking at the awareness, the treatment, and the under control, as Dr. Parikh was talking about, you can see that the figures are dismal. But what is most important in this is that look at the overall graph of India as far as the awareness, treatment, and control as far as the different states are concerned. Probably Maharashtra is better placed, but there are many states which have to really look into this matter much more seriously. And this is the WHO latest release. And this is also supported by an ICMR National Family Health Survey 5, which has been released last month. And you will be surprised to know that the number, despite of wonderful interventions that we have, are rising. And now we have 33% population who are at the risk of developing a cardiovascular challenge related to the hypertension. Now, 33 may not really strike you here. But when I say that 1 in every 3rd adult is at the risk, probably this is a big wake-up call for us. And you can look at this, not only strokes, but ischemic heart disease, peripheral vascular disease, myocardial infarction, strokes. And we all are aware that majority of the challenges are related to the stroke. And we know that, you may prefer to have a myocardial infarction because we have Dr. Wonder, Dr. Manoria to manage us. But Dr. Singh would agree that, when it comes to stroke, it is a very, very difficult scenario you live life with. So look at the hypertension population. This is 33% of diagnosed people. But what is most concerning is it is nearly 50% of the population which is pre-hypertensive. And we have only 17% who are non-hypertensive. So if at all we have to really work on this, we need to really stop hypertension load on the Indian subcontinent. We need to understand that we need to focus, especially these pre-hypertensives, and you need to stop them from getting converted to full-blown hypertensive patients. And what is more worrying is the younger population which is getting affected. Population between age 20 to 40. This was the Dr. Mardikar study initially, and this is what Dr. Shashank Joshi in his site study quoted, that nearly around 12 to 16% of the hypertensive population that we have in India are in the range of 18 to 20 or 18 to 40 years of age. And that is what is most disturbing. So whenever I really talk about it, I always get wondered why being Indians, what is wrong with us? What is that we have not really done right? And then I have realized that look at the possible risk factors. Diabetes, we are all aware, and we keep on talking about in various conferences. How many of us really pay attention to high salt consumption? And more importantly, we need to understand that Indian population is a salt sensitive population. So 1 gram of increased consumption of salt really is going to cause far more fold higher hypertension challenge rise in comparison to the Caucasian or the black population. Tobacco use. Indian population is smartest population to have invented not only tobacco is in a form of smoking. We have, I don't know, brilliantly, I know how many forms of tobacco use that we have invented. Obesity, physical inactivity is a hallmark of the Indian population. And now, especially after COVID, now we also started realizing the importance of mental health and the challenges of urbanization. So with this backdrop, I would probably brief you about what is so new about the European Society of Hypertension Guidelines. This is under the chairmanship of Professor Dr. Mancia. This was released in last month. And I could grab the, ahead of print draft format. It is not yet available in the public domain for the people, but I'll just give you what is. And yesterday only I was talking to Dr. Wonder, and I was wondering what is there, in this. And when I went into the detail, this is almost 200-page document that they have released. And I was mesmerized. I'm really, really happy to say that this is one of the best guidelines that has been ever released in the entire history of the hypertension guidelines. And what is new? They have modified and simplified the criteria of evidence grading recommendation. It's beautifully done. They have talked about the office blood pressure, the ambulatory blood pressure, the home blood pressure at the different demographic situations. They have also come out with the new hypertension mediated organ damage measurements and what are the simplest ways of measuring them and how do you assess the risk factors. And not only assess the risk factors, they have updated the lifestyle interventions. Not only that, they have also updated the targets of the antihypertensive therapies and the possible considerations were given to the heterogeneity of the population. But what was most important and what I really loved about it, that they have included beta blockers as the major antihypertensive drugs, which were not there, unfortunately. And we being under the Professor Dr. Wonders and Dr. Monoria's leadership, we kept on talking about different forums about the importance of having beta blockers. But unfortunately, it had a beating in the European world, in the Caucasian world. But these guidelines have got beta blockers back again into the show. Not only that, they are looking into the details about the various additional comorbidities, and probably Wonder Sir is going to talk about it. I'm not going to go into the details about it, but these are all the new things which have come up. It is a magnificent guidance that you have. Of course, they have again, insisted on the importance of measuring blood pressure in a correct way. And this is what we are all aware about it. I think we need to start more and more implementing into the practice this. Not only that, what is most wonderful about this is that they have considered many intervention factors like what are the factors which will increase blood pressure, what are the factors which will decrease blood pressure. ESH guidelines also have talked about the possibility of the genetic exposure. And most importantly, they have re-emphasized on the lifestyle change, apart from the environmental factors. So they talked about epigenetics, they talked about metagenomics. And this is what exactly is the latest, I would say, various readings and the risk stratification for the hypertension, where now stage 2 is not the number. It is stage 2 is the blood pressure reading along with the hypertension mediated organ damage or a CKD, which is around grade 3, or if there is diabetes. The moment somebody has diabetes, the patient has to be classified into a stage 2 hypertension. And of course, stage 3 again is not a number. So this is the latest risk stratification. So even a blood pressure reading of around 140 or 90, if the person is associated with more than 3 risk factors, probably he falls into a high risk to very high risk group. And this has to be understood very well. Not only that, ESC has also come out with the clear guidance as far as the home and the blood pressure monitoring. The document is available now online, but you need to really try and struggle and find it out. But once you get it, you will really love it. And I would strongly recommend everybody to go through these guidelines. And not only that, they have also suggested the best way of assessing the patients of hypertension. Apart from the body habitus, they have also insisted about the signs of the secondary hypertension. More importantly, now in the investigation list, they have added a new investigation in a form of cystatin C. And one more new thing which has come, apart from the regular investigations that we order, is usually the blood calcium levels that they have started insisting on. And they have also suggested screening to assess the hypertension mediated organ damage. And they have looked at not only the ECG, but also urine albumin is mandatory. Looking at serum creatinine and eGFR is mandatory. Apart from that, you need to also screen for the cardiac challenges in the form of echocardiogram. That is necessary. And Dr. Monoria is going to talk about this. Also, they have suggested that most of the patients would require, and especially in the tertiary care centers, would require evaluation of either aortic or carotid pulse wave velocity, which will definitely tell you about the vascular health. And this is what they have classified the advantages and disadvantages of the various methods to assess the left ventricular function or the cardiac monitoring. And they have weighted it on the sensitivity and specificity. And you can clearly see they are there in this ESH guidelines 2023. They also talked about when to refer the patients to the specialist. I think this is very, very important. We have to all get sensitized that what is the time when a specialist should come into the picture and when you should, suspect somebody to have a secondary hypertension. This is a typical guideline directed medical therapy and a medical approach. What is more, I would say, surprising, I would say, or is the numbers, which they have suggested to initiate the pharmacotherapy. If the patient is without any hypertension mediated organ damage, probably they have accepted the range of around 150 or 95, which is little surprising to all of us. Probably there is going to be a big debate again in the international forum and with various experts that we have nationally as well as internationally. But I am sure that, this is one of the things which is probably needs to be looked into very, very effective. And look at this. These are the recommendations where you can see on the left, you could see the various recommendations and statements. And on the right, you can see the class of recommendation and the level of evidence. And everywhere they say that if the patient who is in between the age of 18 and 79, if he or she records a blood pressure of 140 or 90 on 2 different occasions, then probably you need to not only initiate the lifestyle change, but also you need to initiate the patients on with the pharmacotherapy. If the patient is above 80 years, usually the acceptable systolic range is around 160, but that's not a golden rule. If the patient does not have any comorbidities, and if he or she is able to handle it properly, you can even get the blood pressure down to around 140. So they have subclassified depending on the various age groups between 18 to 64, 65 to 79, 65 to 79 with the isolated systolic hypertension. And they have come back for the management policies with a good class of recommendation as well as level of evidence. What is most lovely about it is this, that they have clearly uttered that systolic blood pressure below 120 and diastolic of less than 70 is not necessary to really understand the importance where to stop. We need to all understand this. This is what the simplified flow of the guideline directed medical therapeutic interventions. Stage 1 hypertension, while you still have got the entire platform open, but still the drugs of choice are ACEs and ARBs. But the patients, those who have got stage 2 hypertension or high or very high risk cardiovascular risk, really they all should be initiated with the combination of the therapy. And again, you can clearly see this beautiful diamond has come back with beta blockers, which was missing from the guidelines, have come back again. And these are all the different drugs that we have. We have again beta blockers coming up here. And of course, these are the indications for the guideline directed medical therapies. This is our antihypertensive team that we have. You can clearly see the champion drugs are still the ACEs and ARBs. And this is what exactly features into the stepwise management of the hypertension as far as the European guidelines are concerned. Right? Last 2 minutes, I'll be taking you through on Indian hypertension guidelines for Dr. Wonder and the entire team, along with Dr. Manoria, Dr. Parikh. I was also a part of the team. We looked at and we also recommended on the similar line. Younger the patient, really, you need to start on with the ACE and ARB, but there we recommended beta blockers in the younger population. In elderly, really, we went back to calcium channel blockers and diuretics, and here we were talking about thiazide or thiazide-like diuretics. Lastly, along with pharmacotherapy, there are 10 S commandments for the Indian population to be practiced, because a good lifestyle change is as good as one or even two therapeutic interventions. Number 1 is salt restriction. Number 2 is sedentary lifestyle change. We need to start it and we need to go back to our schools, because if you start in the adulthood, well, you are chasing the lost ball. We need to insist on adequate sleep. We need to teach people to de-stress and manage their stress regularly and adequately. We need to have a strict control on sugar. We also inform the younger population that if you keep a control on blood pressure, it will give you a better sexual life. Not only that, we need to teach our youngsters, our generations, to reduce down on the sad fats and get exposed more to sunlight. And lastly, awareness has to come from the school. And that is the reason why social media has to play a big role. And I believe Dr. Girish Mathur, Dr. KK Parikh, the entire API and the IACM team is seriously considering, improving the awareness. And Dr. Girish Mathur has already taken a step beyond in going on the API website about this awareness initiative. So these are recently, published various guidelines and various values. What is most important for all of us to understand is this, that whatever the guidelines that you follow, we need to stick to the guidelines and try and use the guideline mediated and the guideline directed therapies to achieve the best possible control. This is my last slide. I love this, so I thought that I'll share this. This is from the hieroglyphic of the ancient Egypt. I could find it out that 1/4 of what you eat keeps you alive. The other third, 3/4 keeps your doctor alive. I think. Thank you very much for your attention. I would be very happy to really have a debate and discussion once everybody's presentations are over. Thank you very much. Over to you, Dr. Singh.
Thank you, sir, for your excellent and lucid presentation. And we learned a lot on the new guidelines of hypertension. And these things are really new to us. And now I hand over the mic to our moderator, Dr. BP Singh, sir.
I must congratulate Dr. Mangesh Tiwaskar for the excellent presentation, and especially this new guideline from the European Society that has recently come up with just 1 month back. And Dr. Mangesh, just because this dogma of 140/90, even Indian guidelines say 140/90 should be the cutoff mark. The European Society also says about this, just now you have put it that 140/90. But there are a lot of cry about that. 130/80, that should be the cutoff for the hypertension. What do you say about that?
So in fact, in JNC 8, it was 130/80. Then if you really remember, then the International Hypertension Group came together and they released the guideline where for the first time they talked about 140 or 90 and 130/80. But if you really look at the analysis, the meta-analysis of the various trials, and this was done by Dr. Sripal Bangalore from from New York, and he has shown that this 10 millimeters of both systolic and diastolic has not impacted too much as far as the cardiovascular morbidity as well as mortality. So, but then probably especially in the population where you are so much exposed to the prevalence and of the pharmacotherapy, and especially in the United States, which is usually an insurance-based therapy, people, lot of patients will become labeled as hypertensives, and it can impact their insurances as well. So there was a big debate which was on. And now, in fact, the European Society, now the latest guidelines is 150 or 90. So that they are 150 or 95 for the stage 1 hypertension patients without any target organ damage. So probably there is going to be a little debate again in the entire community. But then I probably am liking it, to be very honest, because that gives you a little bit more confidence and also helps your patients to understand and accept. Quite a few times, if you really say was 140 or 90 hai, first reading hai, probably first time diagnosed hai, patients are even refusing to accept the lifestyle change. So at least that gives us an opportunity to really prove it that yes, now this is the time that you need a pharmacotherapy, I believe. And I would also love to hear comments from Dr. Manoria sir and Dr. Wonder sir.
Yeah, thank you, Dr. Mangesh. One of the very important topic that in India, still we are more focusing about the clinic office BP measurement.
Yes.
But the message is clear cut from the European Society or all other society that home monitoring of BP, because most of the places this ambulatory BP monitoring is not available. So
yeah,
in Indian scenario,
two people in India have started that awareness campaign.
Mm-hmm.
Dr. Wonder and Dr. Muruganathan.
Yes.
So they were really passionate about, deciphering the knowledge of, importance of home blood pressure monitoring. And on the hypertension day, I still remember these two guys have distributed multiple, digital BP measurement apparatuses to many people and many houses as well. So it was amazing. And now it has started coming into the guidelines, even at the international level. Indian guideline 4, hypertension guideline 4, they're the first people to talk about the importance of home blood pressure monitoring. We talked about ambulatory blood pressure monitoring every time, but we never talked about home blood pressure monitoring. Now that has come up in a big way. So out of the office blood pressure measurement as now one of the most important diagnostic feature, especially when you are talking about masked hypertension or a white coat effect. Yeah.
Now, what about this dosing, drug dosing, whether it should be in the morning or in the evening? What is the current scenario?
Yes, I'm sorry. Good point that you have brought out, and that was there in my slide, but I could not talk about it. But this is another change that European Society of Hypertension has come out with. For the first time, sir, they have said that irrespective of whether the patient is on with a once in a day therapy or a twice in a day therapy, the antihypertensive can be given either at morning time or evening time. Initial guidelines have suggested that if somebody is on with a once in a day therapy, the best time to give is usually in the evening times or night times. And that was, thought to be taking care of the night deepers and all that. But these guidelines, they talk about that antihypertensives can be given at any time, whatever is the time which is convenient to the patients and the treating doctor. So this is another new thing. And thank you for bringing out that point, which I forgot to mention.
Thank you, Mangesh. Is there any question in the chat box?
I would love to hear comments from Dr. Manoria, sir. And thank you, Dr. Subhash Chandra, for being there, and including Dr. Singh, MM Singh, sir, and Puneet, and everybody. Thank you very much.
Sir,
the comeback of beta blocker is a great sigh of relief for us.
Great news, sir. It is a superb
And secondly, they've also included noise, air pollution, uric acid, and other factors which should be considered.
Right. Wonder, sir, your comments, sir.
Excellent presentation, Mangesh. One of the best presentations that I've ever heard on hypertension. And we are all actually equally excited and would want to have debates and discussions on the latest European guidelines, because they do mention about a lot of changes that have happened. And most of them you have already mentioned. One another thing, the ISH guidelines had mentioned about starting therapy with a combination. Now the Europeans are also saying that from the first stage itself, very few selected situations you can use monotherapy. So that is another area which is being emphasized now.
Yes, absolutely. Thank you very much.
So I think we shall go to, I would request Dr. Puneet Saxena, sir, to introduce our great speaker, great learned speaker, Dr. P.C. Manoria, sir. Dr. Puneet.
Thank you very much, D.P. Singh, sir, and I thank the whole IACM team to have organized such nice online series. And in that continuum, we are discussing such an important topic of hypertension. I just heard such a nice lecture from Dr. Mangesh Tiwaskar. So I'm extremely thankful to Dr. K.K. Parikh Saab, Dr. M.M. Singh Saab, and Dr. A.K. Gupta and other team members of the IACM. So now we have another illustrious speaker with us, Dr. P.C. Manoria, who was past president of API, and he was Dean ICP, and he was president of Cardiological Society of India also. And he has been such an active academician and has organized so many national and international conferences, and have edited more than almost 30 books and almost 74 papers in national and international index journals. So we want to hear him on the newer facets of hypertension. And I welcome Dr. Manoria and ask him to enlighten us with his talk.
In fact,
Thank you.
Puneet, you should have introduced Dr. Manoria, sir, as teacher of all of us.
Okay, it's okay.
Yeah, he is teacher of teachers, in fact. So that.
So good evening, everybody. After hearing the mesmerizing lecture from Dr. Mangesh, I will not be talking about the guidelines. So what I'm going to speak today is hypertension, new facets, looking behind the number game. All of us know the numbers of blood pressure are very important and crucial in hypertension. And the World Hypertension Day 23 has rightly emphasized on accurate measurement of blood pressure and its control to live longer. And the guidelines cover the number game with great precision and perfection, as you heard, and we keep on hearing the masterly lectures from Dr. Wonder also in terms of diagnosis, initiation of treatment, and targets for BP control. But behind the number game, there are a panoply of facets which are important and of interest to the clinicians and which are not often discussed. So the first issue I'm going to discuss is that the mortality in a controlled hypertensive is 2 times compared to a normotensive, which means you're a hypertensive patient, your blood pressure is controlled. You do not become at par with a normotensive patient. So what are the various reasons why the mortality in a controlled hypertension is 2 times compared to a normotensive? The first important reason, as you can see, is that the controlled hypertensive patients are not immune from atherosclerosis. A controlled hypertensive patient continues to get acute myocardial infarction, continue to get stroke, and so on. And the second reason I will discuss is fibrosis in the cardiovascular system. Now, very important to realize is that the antihypertensive agents, they only decrease the blood pressure related complication, which means they will decrease left ventricular failure, they will decrease hemorrhagic strokes, they will decrease dissection, but do not provide atheroprotection. And very exciting data emerged from the HOPE-2 trial, I think all of us are familiar with. Just to remind you that when these patients were treated by antihypertensive agents, candesartan plus HCT, here you can see there's no reduction in the ischemic endpoints, but only 10 milligram rosuvastatin was added. You can see a significant 24% reduction in the ischemic endpoint. And the Ascot LLA also was in favor of this approach. The second issue, which is now being increasingly realized, is because we can see fibrosis with LGE CMR, and this is the broadened aspect of the hypertensive heart disease. Previously, we used to consider left ventricular hypertrophy as a hypertensive heart disease, but now several new facets have been added. Now, the first issue is you had fibrosis in the myocardium with CME. These are the white dots you can see. And if a hypertrophied ventricle is also fibrosed, it becomes more prone for ventricular arrhythmias, it becomes more prone for sudden cardiac death, and more prone for development of heart failure. In fact, if the ventricle is also scarred besides being hypertrophic, as we see in other disease also, whether it is a hypertrophic cardiomyopathy or they are also more prone for sudden cardiac death. So scarring is bad. Even those centers who operate for aortic valve replacement, some of the centers these days look at fibrosis also besides hypertrophy. So if the ventricle is also fibrosed besides hypertrophy, in a patient of aortic stenosis, the result of surgery are comparatively less good compared to a ventricle who's only fibroid. The second place where we look at the fibrosis in the left atrium, as you can see, A, B, C, D, different grades. And if your left atrium is also fibrosed, you become more prone for development of atrial fibrillation. The other importance of this is some of the interventional cardiologists who perform RFA, if the atria is fibrosed grade 3 or grade 4, the probability of sustaining a sinus rhythm are remote. So they sometimes look at the atrial fibrosis, and then fibrosis also occurs in the larger artery, in the smaller arteries, and all of us know our young arteries are compliant arteries. The normal pulse rate velocity is somewhere 8 meters per second, but the impulse goes from the systole towards the periphery. It comes slowly, and when it comes back, diastole is already been started. But if you have an aortopathy, which means increased fibrosis, less compliant aorta, what will happen? The pulse wave velocity increase. So what happens? It goes and comes back very early, and the patient is still in the systolic phase, and this creates a lot of distressing effects on the patient. You can have increased central aortic pressure, increased afterload, increased pulsatile strain, which may plaque rupture, no diastolic augmentation, which occurs in a normal individual, and decreased coronary perfusion. So the issue is there any solution to minimize fibrosis? We do not have any randomized controlled trial, but very exciting observation emerged from the long-term follow-up of the LR trial. You can see significant reduction in the conduction system disease with lisinopril compared to CTD or amlodipine after 5 years follow-up, despite the fact that the blood pressure was higher in the lisinopril group compared to the other arm. It seems that antifibrotic properties of RAS could play a role, but we need more data on this. And therefore, we should adopt a disease-centric approach. It means you don't only look at the numbers of blood pressure in terms of 24-hour control, the nocturnal blood pressure, the morning surges, the blood pressure variability, but also focus on the small and large vessel remodeling. Large vessels produce strokes, and the small vessels produce lacunar infarcts and the cognitive decline. The second issue, which is again not often discussed, is the target heterogeneity, which means how does our target organ respond to lowering of blood pressure? And when we look at this issue, if you look at the brain, lower systolic is better, lower diastolic is better. So this is data from the ACCORD trial. All of us are familiar with it. 120 millimeter was compared to 140. The trial was negative, but when the data was analyzed from the point of view stroke, there was a benefit. And we have also data from the INVEST trial. For stroke, lower is better. There's no J curve. But when we look at the heart, lower diastolic blood pressure is bad. This is again subgroup analysis from the famous HOT study. With lower blood pressure, less than 90, less than 85, the ischemic events in the brown color are always more compared to the non-ischemic events. And again, the INVEST trial shows as you lower blood pressure, if it is lowered below 70, you can see the myocardial infarction rate continues to increase. And we have this J curve for coronary circulation, and this usually starts when you lower blood pressure below 70. And this again is a very interesting publication from JAG, which shows that compared to a diastolic blood pressure of 80 to 89, a diastolic blood pressure below 60 more than double the odds ratio of high sensitivity cardiac troponin 3 levels equaling or exceeding 40 nanograms per ml and increase the risk of coronary events, again supporting the J-curve effect. And again, this also another study which shows that if you are revascular, you're a patient of coronary artery disease, you tolerate lower diastolic pressure much better. The third issue, which is now discussed these days, is increased sympathetic activity. The guidelines, of course, at the moment do not discuss because it requires a lot of data. All of us know Indians are hypersympathetic. This is one publication. This is another Indian publication from our country, which shows that an increase in heart rate by 10 beats per minute is associated with 14% increase in the cardiovascular mortality and 20% increase in the total mortality in patients with hypertension. You can see resting heart rate is elevated in Indian hypertensives, and it correlates both with systolic and diastolic pressure as well as with the BMI. And the Indian heart study, all of us are aware, showed increased heart rate in the Indian subsets, as you can see on this slide. What is very curious is whether your blood pressure is controlled or not controlled. If you have higher heart rate, there are increased chances of cardiovascular events. This is data from the value trial, and you can see all these events are more if your heart rate is higher. And there are several trials which have shown. The life study also shows that your all-cause mortality is more if your heart rate is faster. And this is again in West study. You can see as the heart rate increases, the cardiovascular events increases. As you can see, these are the events. And sister study also shows whether you're a man or woman, all-cause mortality increases as the heart rate increases. And all of us are aware of the distressing effects of the sympathetic overactivity, not only in terms of hypertension, but several other diseases I'm not going to discuss. And inhibition of the sympathetic system does provide beneficial effects. But the big unanswered question is, can we offer beta blockers in controlled hypertension with increased resting heart rate, even in absence of CAD, heart failure, arrhythmia, despite lack of recommendation? But this is an unresolved issue at the moment, and no definite guidelines can be issued. The other issue is isolated systolic hypertension in the young. Isolated systolic hypertension in elderly is well known. All of us have treated this in large number of patients, but now we are coming across young individuals who have isolated systolic hypertension in the young. Most of them are IT workers, they don't sleep properly, and beta blockers produce very good response compared to the other antihypertensive. And this is another publication which shows that isolated systolic hypertension in young people is not spurious, should be treated. More and more data is likely to emerge in few. The other important issue which also requires discussion is cognitive decline. Uncontrolled hypertension, particularly with increased blood pressure variability, is a very common cause of premature cognitive decline. In fact, one of the reasons why treatment should be started early in hypertension, should be well controlled, is cognitive decline. This is a 25 years follow-up data from the cardiac study, which shows blood pressure variability correlates with development of cognitive decline. The next issue is vascular age, again, which is of great concern to us. If your vascular age is higher, you are likely to get events in near future. So vascular age, there are many factors, but hypertension is an important factor. And now you can calculate the vascular age non-invasively from the peripheral blood pressure, from the augmentation index, from the pulse wave velocity, and the central aortic pressure. So I'll show you three illustrations. This is an individual, chronological age is 54, vascular age 57, reasonably good. The second individual is chronological age is 37, vascular age is 46, bad. And the third individual, chronological age 54, vascular age is 73, is very bad. The other issue, which of course time and again we discuss, is in Indian hypertensive, there's clustering of risk factors. You can see many risk factors are coexistent in patients with hypertension, as you can see. So what we give to the patient is this mobile number, which means 130/80 is for your diastolic, systolic, and diastolic blood pressure. 100 is for LDL cholesterol, although now we desire it should be less than 70. 7 is for HbA1c, and 0 is for smoking. So they can feed this number and see whether their concomitant risk factors are also taken care of. Quality of life is a very important issue in hypertension, because hypertensive patients, hypertension is an asymptomatic disease in vast majority of patients. very difficult to make an asymptomatic individual feel better. Rather, he may be made worse with treatment. So the treatment of hypertension is a long drawn process over the years, and therefore special emphasis should be laid on the quality of life. We should not forget life is not merely being alive, but being well. Our hypertensive patient should not only live, but also feel well. And special care should be taken by selecting antihypertensive to young individuals. And digital intoxication, as you can come here, skimming as a big barrier for health and prevention of non-communicable diseases. You can see smartphone, WhatsApp, Google, LinkedIn, Facebook, Instagram, Twitter, Snapchat, Tinder. The young generation is busy with all these social media, which create a very adverse effects on the health of the individual. And what we propose is do digital detoxification instead of a conventional fast. So do not use social media at least twice a month, preferably every week for 24 hours. The control rates, as was highlighted by Dr. Mangesh, is dismal. But the problem is you have to realize that medical fraternity alone cannot improve the control of blood pressure, because several patients of hypertension are outside the reach of a medical fraternity. So all potential stakeholders in hypertension should be involved: non-government organization, government organizations, healthcare professional, scientific organization, electronic print media, and social workers. Only when we adopt a cohesive approach, we will be able to improve the fingers. And the last issue is hypertensive in free India. The treatment of hypertension, we have very good drugs which decrease morbidity and mortality. They prolong life of the individual, but all these treatments do not decrease the number of blood pressure patients. The number of blood pressure patients are progressively increasing. Our aim should be to stop hypertension, stop hypertension, stop hypertension, and build a hypertension-free India. And this is only possible by primordial in prevention, primary prevention. All of us know prevention of emergence of risk factors in population in which they have not yet appeared by individual and mass health education. And the best targets are these nursery kids at the scene, that if they are taught lifestyle modification right at the stage, they continue to follow up in the latter years of life, and the decreased incidence of cardiovascular disease. Data from the Familia study, data from Spain with Valentine Fuster. And therefore, our aim should be to make hypertension free India. This is a very difficult task, will require several decades. Thank you very much for your kind attention.
Excellent deliberation, sir. Dr. P.C. Manoria, sir, hats off to you. And we need clapping for this. It should have been the open session, yes. And we could have the standing ovation too, sir, to Dr. P.C. Manoria, sir. Excellent, sir. And you have rightly pointed out so many new facets of hypertension. Just even if the patient becomes controlled hypertension, that is still the mortality is twice than the normotensive patient. That's very important. Not only that, what about the role of statin in this management of hypertension, sir? You have pointed out about the HOPE-3 trials about that. Whether all hypertensive patients should be put on that? Sir.
Yeah, the data is on intermediate risk. The HOPE-3 was on intermediate risk, but it seems that the HOPE-3 very clearly showed that if you use antihypertensives, atherosclerosis is not going to be prevented. And the targets for LDL are also getting lower and lower. If you want to decrease events, guideline will say less than 100. If you want to arrest the progression of atherosclerosis, less than 70. If you want to regress atherosclerosis, less than 50. So it depends on what do you want.
Sure. And again, this lower is not always better, because usually used to teach our students that lower is better if it can go even to the 60, but you know the cardiac events has increased, that the lower is J curve is there, and so the message is quite clear in the cardiac.
LDL lower is only better.
Yes,
it applies only to LDL, not to glucose, not to blood pressure, as you pointed out.
Yes, sir. What about the Indians? Because Indians are so sensitive. Earlier, Dr. Mangesh has also talked about the beta blocker, even the European Society. And most of our prescriptions, sir, if you start with this ACE inhibitor and the ARB, they are not controlled. We have to add the beta blockers in majority of prescription, large number of prescriptions. We are adding this. Sir, one comment about that, about this sympathetic activity and the use of beta blocker in Indian scenarios.
Indians are hypersympathetic, has been shown by our Indian data. The problem is if your controlled hypertension, your heart rate is elevated. We don't have any guideline or any trial, but it seems logical if you add beta blocker, this would benefit. And as you said, sometimes blood pressure is not controlled by other agents. If you add a beta blocker, particularly those who don't sleep, they work in the night, IT professionals, so on, blood pressure is usually controlled.
So is there any question in the chat box? I don't see. So chairpersons, any remarks? Dr. Puneet? Dr. Puneet Saxena? So thank you very much, Dr. P.C. Manoria, sir.
And now listen to Dr. Masterly talk by Dr. Vanda, waiting to.
Sir, so now we have got the legendary figure, and all physicians across the country know the name, that is Dr. Gurpreet Singh Wander, sir. Welcome you, sir. And Dr. Wander, sir, has been the professor and head of the Dayanand Medical College and the Hospital, Ludhiana. And he is a B.C. Roy awardee. He has been the president of API. He is the chief contributor of cardiology section of API, chief editor of yearbook this 2018, and lots many more. He just now is the director of PRF and doing a lot of activity in the research activity. And sir, over to
So Dr. Singh, you should
Dr.
have
Wander,
said you're
sir.
champion of champions, you can say.
Sir, sir.
Thank you, Dr. DP Singh, for having introduced all of us. I must thank at the outset Dr. Parekh sir and Dr. MM Singh and Dr. Gupta for being the guests of honor. And we just had two very masterly presentations on hypertension. And it's been really educational for me to listen to Dr. Mangesh and Dr. P.C. Manoria, who have really actually, Mangesh so beautifully talked about the epidemiology of hypertension, how it is increasing in our population, how more and more people are getting afflicted. The control rates, he gave us some of the latest data from WHO and the national guidelines that we have. Very beautifully, Mangesh discussed home blood pressure, role of office blood pressure, and how some of the other guidelines actually are looking at, and how the Indian guidelines have looked at. It was exhilarating to listen to Dr. Manoria. These are some of the issues which sir has touched upon, which actually we tend to ignore in hypertension. And we, as he's at the outset said, number-centric is one thing. The ALLHEAD trial did tell us that whatever you do, actually the blood pressure levels have to be controlled, and that makes actually all the difference. But Mangesh did discuss that we now have stages of hypertension and grades of hypertension, and the stage actually is what is going to determine the risk of your patient. So rather than looking at actually just the numbers of blood pressure from grade 1 to 2 to 3, it's the stage, depending upon whether your patient has other risk factors or not, patient has subtle evidences of target organ damage, or has evident actually strokes, coronary disease, or renal failure. So having listened to these luminaries, I'll just, I think, touch a little bit upon the special situations actually in terms of hypertension, as to how we need to alter our the way we manage patients of hypertension. I'm just going to cover a couple of these special situations which I thought need merit, in which there has been a significant change in the recent guidelines from the previous thinking. We all know hypertension in pregnancy is actually different from hypertension that we treat in other situations. And previously we used to be taught that 150 by 100 was the threshold for starting antihypertensive therapy. But the European and also most other guidelines have now actually brought this down, because we have merit and we have evidence that the maternal and the offspring actually outcomes are better in terms of less stillbirths, better outcomes for the maternal parameters also. and you need to treat blood pressure by 140 by 90 whenever it goes beyond, almost similar to what we do in other situations. Another difference in pregnancy-related hypertension is, although we today advocate, the latest guidelines have suggested that office blood pressure still remains actually the method by which you will diagnose hypertension. Although the Canadian guidelines now say that you need to have a combination of office and home blood pressure. So subtle differences will exist amongst different guidelines. But this is an area in which actually, in spite of the fact that we today use the digital, the oscillometric devices, they have replaced the manual blood pressure recording. The guidelines still say that we need to measure the blood pressure manually in pregnant women, because you will not be as accurate with the oscillometric devices. The third important thing which has been suggested is that when patients are on treatment, you do not bring their blood pressures to below 80. Just as Mangesh said, that in other situations, bringing blood pressure to less than 120 by 80. Dr. Manoria did touch upon the discrepancy between the brain and the heart and the kidneys. And in that, in fact, he talked about the brain getting benefit with control of systolic and diastolic blood pressure, the heart getting better effects with control of systolic blood pressure, but that both actually, that evidence is less with the renal in terms of improvement. And patients who have proteinuria, obviously we get greater benefits, but this disparity exists, and depending upon what comorbidity, what target organ damage your patient has, your aggression in terms of reduction of blood pressure. So individualization of therapy is of course very, very important. Labetalol, we know today, is the drug of choice in pregnant women. Alpha-methyl dopa is sadly very difficult to be made available in India today. And extended release nifedipine is still talked of world over as an alternative to labetalol. As compared to all other situations, a very significant difference: you escalate the monotherapy, you keep going up in a pregnant woman. Combination drug therapy, which is the essence of treatment of hypertension in other situations, actually is to be used only after we have fully uprighted with monotherapy. So this is another very significant difference. We all know ACE inhibitors, ARBs, are not to be used in pregnancy, and even women who are contemplating pregnancy, we should avoid them. Women who are high risk, who've had preeclampsia before, very obese women, elderly, nulliparous, they are the ones who should be started on actually aspirin prophylactic dose from 11th week and then continued till 35 weeks. Hypertension beyond 160 by 110 needs hospitalization and magnesium sulfate. So these are some of the actually changes that have happened in terms of our thinking when we treat hypertension in pregnant women. This is an area which, as physicians, we do need to intervene. We all know beta blockers are not the agents of choice. Pregnancy is a volume contracted state, so diuretics are not preferred. And in fact, if you don't use nifedipine, you can of course use amlodipine as a second choice agent. But labetalol remains as the first choice agent for management of pregnancy. Let's see a large chunk of patients who have coronary artery disease, how we look at these people. Now, patients with hypertension and coronary artery disease, as we all know, the ACE inhibitors or the ARBs plus beta blockers, that would be, beta blockers are actually have gained in terms of their reputation and usage in coronary disease, heart failure. Although in hypertension, as Mangesh and Dr. Manoria were discussing, amongst Indians, since the India heart study showed our heart rates were higher than others by the grade of 10. So ACE inhibitors and beta blockers should be preferred. Patients who have angina, you can use dihydropyridine calcium channel blockers, that is amlodipine. But those without angina, you can even use diuretics. Another significant change or in terms of aggression which has happened, the American guidelines already said actually that people who have a high normal blood pressure, which is above 130 by 80, you should start treatment in patients with coronary artery disease. The European guidelines, we have already said in our Indian guidelines in 2019, and the European guidelines also say that, so the lower thresholds are to be used for starting treatment in patients of coronary artery disease, although the target remains the same. Patients with angina, of course, we will treat them with beta blockers and both dihydropyridine and non-dihydropyridine calcium channel blockers. Heart rate, we have already dwelled upon it. The European guidelines have also talked of heart rate. Now, heart rate has been accepted as a risk factor, as a confounding factor in patients with hypertension. And we all want to have actually lower blood pressure and the heart rates along with lower blood pressure, something Dr. Manoria was saying within the range of 60 to 80. We also know patients who have ischemia documented but do not have any obstructive coronary artery disease, that is, who are chronically coming to our patients, the INOCA patients and myocardial infarction with no obstructive coronary artery disease. These are patients, of course, who should be treated with RAS blockers, beta blockers, and calcium channel blockers to effectively control their blood pressure and thus impart benefit to these people. Atrial fibrillation is an important consequence of high blood pressure, and patients who are in atrial fibrillation actually, again, what level of blood pressure control should we try to achieve? The thresholds and targets in individuals who are in AFib has to be the same as in hypertension. Otherwise, you should at least take 3 readings because we know variations in blood pressures occur. And now we have a lot of data which shows that do not try to reduce the heart rates. See, normal sinus rhythm heart rates we want lower, but in AFib, since the atrial boost to the ventricular filling is lost, we do not try to bring their heart rates to less than 80. In fact, resting heart rates should be lowered to below 110, but don't be very aggressive in terms of bringing their heart rates to even lower levels. And so if patients' heart rates are above 80, you will treat these patients with ACE inhibitors, ARBs, and beta blockers, because we have evidence, subtle evidences that they have anti-fibrillatory, effects that prevent fibrosis in the heart muscle. But if the blood pressure is not controlled, then obviously you will add a dihydropyridine, or you can even add a diuretic to this algorithm. Patients who all patients who have hypertension and who have a CHAD score of more than 2 in women and more than 1 in men. In fact, those who are hypertensive, they should be on the newer oral anticoagulants, whether you use rivaroxaban or apixaban or dabigatran, that's your choice. But these are preferred over the vitamin K antagonists because we have evidence the cerebral hemorrhages are less. The less harmful GI bleeds might be higher, but overall there is a benefit. But control their blood pressures to less than 160 systolic and then put them on oral anticoagulants. Another important actually issue, non-dihydropyridine CCBs, diltiazem and verapamil, they can interfere with oral anticoagulants and they can increase the bleeding risk. So avoid these agents amongst patients for rate control. Try to control their heart rates with beta blockers if you have patients in atrial fibrillation. Stroke and hypertension are very actually has been a very contentious issue. It's a good algorithm which has come in the latest ESC guidelines. How you manage a hemorrhagic stroke is very different. We Indians have a higher percentage, almost 20 to 25% of strokes in India are hemorrhagic, whereas 75 to 80% are ischemic. But world over, the prevalence of hypertension, hemorrhagic strokes is much less as compared to us Indians. Now, within 6 hours, you need to be aggressive because you will avoid the expansion of hematoma and you will try to bring their blood pressures to less than 140/90 in a hemorrhagic stroke. Beyond 6 hours, be a bit slow and do not try to bring their blood pressure because whatever has to happen has already happened. But if the blood pressure is more than 220, obviously you will like to bring it below. Now, this is based on some data which has come in the last actually 3 years, some studies published in the New England Journal of Medicine. So this change has happened actually with the current thinking that you bring their blood pressures to below 180. You may not want to bring it below the intensive levels, but certainly it needs to come down. A lot of our patients get thrombolized, but if you want thrombolysis or mechanical thrombectomy to be done, have their blood pressures to below 180 by 105. If the patient is not eligible for thrombolysis and pressure is less than 220 by 120, leave them alone for the autoregulation, and the blood pressure is not going to damage these people. But if it's beyond 220, obviously you need to bring it down to below by 15%. So as I said, first 6 hours more aggressive, bring it down to less than 140 by 90. Beyond 6 hours, bring it to 180. Ischemic strokes, more moderation, depends upon thrombolysis or no thrombolysis. If you are thrombolizing, bring it down to less than 180 by 105. If you are not thrombolizing, bring it down by 15 to 20%. Well, heart failure is a consequence of hypertension. It's a very important consequence. Patients initially have left ventricular hypertrophy, diastolic dysfunction, heart failure with preserved ejection fraction, and then obviously decapitation of blood pressure does occur in these people, and high blood pressure is harmful in this. And this is how you would now, instead of the conventional treatment with RAS blockers and beta blockers and mineralocorticoid receptor antagonists, we all know we have the SGLT2 inhibitors, which have become an essential part of heart failure. And so if your patient is hypertensive, you will obviously want to put them on a SGLT2 inhibitor along with ACE inhibitors, CCBs or diuretics. Of course, we know heart failure with preserved ejection fraction. We have data which shows that women and those in the lower fraction of the heart failure with mildly reduced ejection fraction and lower fraction of less than 55% EF, they benefit from ARNIs. So you would obviously like to substitute the ACE or an ARB with an ARNI, knowing fully well that when you switch from an ARNI, from an ACE inhibitor to an ARNI, you give an interval of 36 to 48 hours because your patient can land into problems. So heart failure, preserved ejection fraction, hypertension again treated, as I said, at beyond 130 by 80, SGLT2 inhibitors class 1, ARNIs to be substituted in women and especially in the lower fraction of ejection fraction in heart failure, preserved ejection fraction. And even we have actually current thinking that the mineralocorticoid receptor antagonist spironolactone can be considered, although the TopCat study was a negative study, but then we know there was a difference between the American and the Russian accurate data. And still a lot of people would like to use these agents in patients with heart failure preserved. Heart failure, reduced ejection fraction, we all treat these people with guideline-directed medical therapy. These days, with ARNIs getting off patent in our country, a lot of our patients are now being shifted. Beta blockers, of course, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. We all know use of non-dihydropyridine CCBs is contraindicated in heart failure with reduced ejection fraction. If your blood pressure is not getting controlled with these very agents that you are treating, don't hesitate from using amlodipine, because blood pressure control still is very important, even if your patient is in heart failure. After you have escalated and gone to the full dosages of a RAS blocker, beta blocker, and an MRA, then obviously the blood pressure control still remains important. This is a combination which was the first afterload reducing agent to happen. So don't forget hydralazine nitrate combination, especially patients who have a chronic kidney disease in hypertension. And cardiorenal syndrome is something that we very commonly have a double, actually, vagary, I would say. We have 5 types. The first 2 are acute and chronic cardio, the heart resulting in the renal complications. And the third and fourth are the kidney resulting in the cardiac in acute and chronic. And of course, the 5th type of cardiorenal. So cardiorenal syndrome is a especially difficult situation in which your patients are at a very high risk. And this is something that you should pick up very early. If you pick it up early and you treat these people aggressively, you will obviously be giving the greatest benefit to your patients. So we've just talked a little bit about the various situations. Now, kidney, of course, is the target and also the cause of high blood pressure. And we need to define what grade or what stage of CKD a patient is in and calculate the eGFR, and then look at, because we know patients who are in CKD, they have much higher CV events when they have, there's an exponential increase you can see, as because it's not only the atherosclerotic and ischemic effects, other things like arrhythmias, sudden cardiac death, arterial calcification, all these complications come up as we go from stage 1 to stage 5 renal failure. And so this is the algorithm which the latest guidelines have given. CKD, when the eGFR is more than 30, you start with ACE inhibitors or ARBs with a CCB or a diuretic. If not, then of course the 3 combination, and spironolactone use with caution because patients can have hyperkalemia, or you could use an alpha-1 blocker or a centrally acting agent. Stage 4 and 5, again, ACE, ARBs plus CCB loop diuretics will come into picture here, because these are the ones which are going to be beneficial in this situation. Although we have a latest trial in the New England Journal of Medicine which shows that chlorthalidone, still we used to teach a couple of years back that don't use chlorthalidone in patients who have stage 4 or 5 CKD. But today we know chlorthalidone reduces blood pressure in this, and so it does figure in these guidelines in this particular situation. So I'll end here by saying that management of hypertension in these special situations needs to be altered actually, since it's not only the blood pressure, but also these associated diseases which we would like to treat and so manage our patients more effectively. Thank you.
I have a question. Am I
Sure.
permitted?
Dr. Mangesh, yes.
Yes. Thank you. Thank you very much. And first of all, compliments, sir, for such a simplified talk. You know, it was just like a baby food that you have served us. It's such a difficult topic to talk about, and you have covered so many beautiful aspects of the whole thing. It was awesome. So my question is usually, and this is related to hypertension in pregnancy. Quite a few times, especially in those women, those who develop probably preeclamptic toxemia or something like that, where on the contrary to probably fluid deprived state, they are usually in some fluid retention or fluid overload stage. So will it be a okay choice to, if at all, consider the loop diuretics in some situations where you would like to probably knock off that extra uh, third space fluid that usually can be a challenge as far as worsening of the peripheral vascular resistance in these patients, especially in those women, those who are may not be classic gestational hypertension, but hypertensive mothers, those who have become pregnant on the therapy, or probably women, those who are developing eclampsia, either preeclampsia or eclamptic toxemia. So there I wanted to have your opinion on.
Yeah, thank you, Mangesh, for the kind words. And of course, yeah, I'm very happy you brought in actually pregnancy, because pregnancy gets neglected and we are so much CAD, atrial fibrillation, stroke, and CKD centric, but then we manage it patients. Well, preeclampsia is, as you said, gestational hypertension is beyond 20 years, and pre-hypertension is someone already has hypertension, but the management principles, the guidelines are the same. The treatment actually, keep in mind HELP syndrome, low platelets, and the complications of a preeclampsia in your patients. Preeclampsia patients, of course, need to be treated aggressively, and blood pressure controls should be effective. Magnesium sulfate is another thing. And as we discussed, combinations will come into play if your blood pressures are not getting controlled. If your patient goes into heart failure, then I would say loop diuretics would be beneficial. If
Yes.
Because see, thiazide diuretics are also going to cause diuresis. So in that particular situation, a smoother situation would be to use a thiazide diuretic. But if your patient is in heart failure, the patient is fluid overloaded, obviously you will treat these patients like any usual patient of heart failure.
Correct. And one more thing that I wanted to understand. A lot of times we do not talk about even NICE guidelines or even the AICOG guidelines they have released on management of hypertension in pregnancy. They have not talked about beta blockers. But somehow in our clinical practice, when we are managing these women, when you are not adequately, and we all are aware, sir, that even though labetalol is one of the choices, but sometimes labetalol doesn't really, actually adequately bring down the blood pressure, isn't it? And with this now poor availability of alpha methyl dopa now with us, really, what is your take on the newer probably cardio-selective beta blockers in these women, especially not like atenolols, but at least this nebivolol, carvedilol, these drugs which are very potent antihypertensives, really will also take care of this sympathetic overactivity that the women they get, especially during the development of the eclampsia. So there I wanted to have your comments.
Yeah, that's a great point actually, because antihypertensive agents choice and the choices that we have in this situation is very limited. And at times one is at pains to actually control their blood pressure and control it effectively. But as they say, actually, I would say mostly the dosages of labetalol that we use are much less than the dosages of labetalol, which are generally given in the guidelines. And it's also being advocated that go up, escalate on the dosages in monotherapy. So I would say go up on labetalol, keep going up on labetalol.
Maybe around up to around 1600 milligrams.
Extent. Then use a calcium channel blocker and then add a diuretic. As far as other beta blockers, as you are also rightly hinting, we have data with atenolol and metoprolol. These actually, you have small for date babies, incidence of birth defects in children are higher. So usual beta blockers, that is metoprolol and atenolol, should be avoided. Newer beta blockers, I will not be able to answer it actually whether we have data, but obviously newer beta blockers are not the same as the conventional beta blocker.
Correct. Thank you very much.
There is one question in the chat box about this end-stage renal disease. Patient on hemodialysis, there is fear of AVF being malfunctioned. If we lower the BP too much, what is the guideline says 130/80. So what should be the right approach?
Yes, absolutely. In fact,
that's a good one actually. See, by the time your patient is on regular hemodialysis and stage 5 CKD, the battle is already lost, and you are looking at other things. You are more looking at reducing cardiovascular risk, and we also know the treatment of hypertension in CKD as it goes up becomes more and more difficult. And systolic hypertension is a very, very difficult thing to treat in end-stage CKD. The targets are obviously less stringent. As I said, the renal benefits, that is why most of the guidelines actually stop short in terms of the targets bringing down in patient, because the renal, as Dr. Manoria was touching upon, stroke, heart and kidney, in fact, in that order, the benefits are decreased. So these the targets would be more liberal, and the best way to treat hypertension is actually regular hemodialysis. So if your patient's blood pressure is not getting controlled, obviously you will use thrice a week dialysis, which is sometimes used less often. This is one situation where I use alpha-1 blockers, where I use centrally acting antihypertensive agents. So some of these less frequently used antihypertensive like clonidine or clonidine, these are agents actually which we don't use routinely. But since hyperkalemia is an issue in a lot of our patients, we have to resort to these agents. But yes, to answer that question, we are more liberal. We are not that stringent. Patients will be asked to miss the dose before they go for dialysis, because dialysis-induced hypertension is a definitive entity and it can make these people worse.
Thank you, Dr. Wander sir, for excellent deliberation. All the three stalwarts doing so good justice. But before we end, because India has got large number of hypertensive patients, and Dr. Manoria sir said the primordial prevention is the answer. Dr. Mangesh, what is the answer of this big silent killer being the awareness is so less in Indian people? How to tackle this issue? OPD patients, doctors are not measuring the blood pressure. How we should take the issue in Indian scenario?
So
Dr. Mangesh,
in fact, very wise point, Dr. Singh. And in fact, that is what probably Dr. Manoria was also, hinting towards is that we need to start making people aware about this preventable menace. So let us understand this menace can be stopped. This can be prevented by simple lifestyle change. If you remember in our days of school, there used to be a physical training school. We never used to have access to junk food. Our foods used to be the tiffins that our mom served us and sent us all to the schools. We used to have every day 1 hour of physical class. We never had access to any junk food available. Televisions were an absolute I would say a luxury in our houses. Mobile phones were not there. We all were in the grounds and all that. So that exactly is the lifestyle that we need to go back. And as Dr. Wander sir and Dr. Manuria also said, and Shashank delivered a beautiful talk couple of days on the digital detox that we need to undergo now. Seriously, we need to really look into that. Talking to adult grown-up people, who are already established hypertensives, probably we are chasing the last boat, sir. And unfortunately, in India, we are not really sensitized. In fact, one beautiful suggestion had come, sir, and which I was really thrilled to know that ki apne, in our school days or in our 10th and 12th standard, this thing, if somebody has got a sport activity of probably more than every hour, or if you're not eating your junk food, 10 marks extra de dena usko. So,
Thank you, Mangesh.
in fact, these are all the things which can be really restarted in the school days. That is the place where probably the primordial prevention starts.
So over
And-
to Dr. Wander sir again. Brief message, how to tackle this issue. When to refer to the specialist. Before that, primary care physician, what is the message?
I would say that hypertension is actually quite a standardized treatment. And unless you truly have a resistant hypertension, hypertension should be treated by primary care physician. And resistant hypertension is when you are using 3 drugs in adequate dosage, when one of them is a diuretic. So most of these people we will be able to treat. Physician, as you were also saying, and Mangesh said, physician inertia needs to be actually countered. Rather, it's not just the patient inertia, it's the physician inertia, which is very, very important. And patient participation in treatment, I think, is very important. One thing I have learned of late is that you should encourage people to use home blood pressure monitoring.
Yes.
But tell them not to react to single readings. Tell them just bring your 7-day reading, the morning, evening reading. That really creates a lot of rapport between you and your patient. So practically, I would say
protocol.
a lot of them. So if before giving them the home apparatus, you tell them that don't please react to any high or low readings, because we are going to use an average of 14. That's one way we can increase the use of home blood pressure and patient participation.
Participation of the patients is very important in tackling this issue. Thank you very much, all the speakers, all the
I think
stalwarts.
Dr. Singh, I think Dr. Subhash Chandra wanted to have a question. So probably
Sir.
his hand was raised.
Can I ask one question, please?
Sure, sir.
Yes, sir.
Lumber sir, please go ahead, sir.
Okay. Dr. Wanda, sir, very nice presentation. It was really nice hearing about all this. So I wanted to ask you, in tough situations when we are having cardiorenal syndromes and we are falling short, at what level of creatinine would you like to discontinue ACE inhibitor, ARB, or would you be looking only at hyperkalemia? One. And second is, what are the alternative drugs that we can use in such patients?
Yeah, that's an important issue actually which bothers. This is one area Dr. D.P. Singh was saying actually. I would say if your patient has CKD stage 3, 4, possibly the patient should be to a hypertension specialist. A primary care physician will probably not be able to monitor their potassium levels. We have data now which shows that you can use actually ACE inhibitors, ARBs, and keep using it. Now, simple logic is if your patient has end-stage renal failure, what are you trying to preserve? And these agents are more beneficial when albuminuria is more. So early stage albuminuria, one needs to keep in mind that that's the stage where you are, and albuminuria is as much a risk factor in terms of benefit as abnormal renal functions are. And as the renal functions deteriorate, the albuminuria itself decreases. So obviously these agents are not going to be that effective. So one has to keep in mind what is the frequency with which you can monitor your potassium levels. Finerenone is yet not available. I think to Mangesh and people in Bombay it's available, but it's an expensive drug. But yes, we have strong data which shows that continue to use ACE inhibitors, ARBs, and even MRAs in patients who have early stage CKD. In the Indian guidelines we had given, because those guidelines were meant primarily for primary care physicians, we gave a cutoff level of 3.5. So we didn't talk, to make it very oversimplistic, I would say, we had said that beyond 3.5, you do not use ACE inhibitors. But subsequent to 2019, we have a lot of data that even in later stages of CKD, you give benefit to your patients if you continue to use the ACE and the ARBs. So it all depends upon a physician, but then one has seen a lot of hyperkalemia in clinical practice. So these are things which should be weighed in terms of how frequency you can monitor. And if your patient is sitting on the edge, say his potassium levels are coming around 5, 5.5, might as well use other agents actually, rather than pushing your patient to a risk.
So can I have a comment
Thank you,
in
sir.
continuation
Thank
with
you,
that?
sir.
Yes. Another point, sir, is this that if you are on with a simultaneous SGLTs on board, then probably you need to be a little more careful in these patients, especially those who are on with ACEs and ARVs. And as Wonder sir has beautifully said that now, really hyperkalemia is a challenge, and as the patients are probably on the hemodialysis, that would be taken care automatically by the dialysis session. So I believe then that will really rob off that scare and fear of hyperkalemia as well. So I think, wonderful points that Dr. Wonder sir has made. And now we are, along with creatinine, we are now more insisting and emphasizing on eGFR monitoring rather than the creatinine. Because creatinine is relatively, I would say, a very, I would say, a poor determinant of the renal health. So I believe eGFR would be a better monitoring tool, and now it is easily available. Most of the laboratories will also yield you eGFRs very easily.
Thank you, sir. Dr. Subhash Chandra Gupta, please go ahead, sir.
Sir, you need to unmute yourself, sir. You need to
Dr.
unmute
Gupta,
yourself.
sir, you are muted, sir. Please unmute yourself. Dr. Subhash Gupta, yes, sir. Please go ahead, sir.
Nowadays, diastolic dysfunction is being talked about a lot. I was going to ask Dr. Wonder, what treatment, of course, it is due to the fibrosis caused by hypertension to LV and LA. What is the preference of drugs he uses effectively in diastolic dysfunction?
So diastolic dysfunction is the initial dysfunction which comes, and it's the systolic dysfunction which subsequently comes. Most of these patients now we classify as heart failure preserved ejection fraction or mildly reduced fraction. And we all know all these agents, ACE, ARBs, beta blockers, MRAs, we did not get mortality benefit in terms of with the use of these agents. So yes, blood pressure control is very important because blood pressure is the main cause for heart failure preserved ejection fraction, elderly, women, fat, these are with OSA, these are the subset of patients who have heart failure preserved. So good blood pressure control is important, but do not expect, the only two agents which have been shown to be beneficial is SGLT2 inhibitors and ARNIs in people with ejection fractions of less than 55. So these two agents should be used, I would say, in patients who have diastolic.
I have got a bit of doubt about using ARNI, but rather I will use diuretic and SGLT2. ARNI is not of much benefit in diastolic dysfunction.
Yes, you are right, sir. You are right. In fact,
Sir, one of the very important question from there is the level of creatinine. How much safe will be using this ACE and ARB? That's the very important questions. Wonder,
that was discussed, I believe. Yes, Wonder sir has already told.
Discussed this issue.
3.5, Dr. Wonder sir has said. You know.
Okay. So thank you very much, sir. That's an excellent evening, excellent presentation, excellent discussion on hypertension. So over to Dr. MPC.
Thank you, sir. Before we come to the conclusion of our today's CME, I would request if any senior members wants to say something. Professor Dr. M.M. Singh, Professor Dr. H.A. Gupta, sir.
Dr. Wonder, you have very correctly and very appropriately discussed all the issues. One thing which is coming to my mind, in early 60s, when I was a medical student, I was or passed MBBS and was doing internship. The antihypertensive drugs at that time used were in the form of acetylchlorothiazide and chlorothiazide. A time came, there was a dispute, it caused a dyslipidemia, it causes hyperglycemia. the drugs went into, let's say, into the waste paper basket. Nobody was used. It was banned in many countries. Again, we found research. And again, we find these drugs for hydrochlorothiazide, and chlorothiazide again has come up. Similarly, about chlorothiazide, which you have told just now, that in particularly in renal failure, many times it was indicated with the raised creatinine, it should not be used. And today again, you are recommending that it can be used and it is beneficial in many aspects. So this is the drugs which is coming up, coming down and up. And mostly sometimes what I have found, in those cases in which there is a labile hypertension or hypertension, what you find, if you give even chlorothiazide once a week, they're very beneficial in controlling their BP control for a month or so, if you do the home monitoring and all that. I think your opinion about chlorothiazide is in the use, particularly in early cases, when other antihypertensive drug may not be so beneficial. Sometime in early cases, or when you have a labile hypertension or hypertension moment, is it not very useful even today?
I think you have made a very important point, because we all agree with you that young age hypertension is more renin related. And so we tend to use RAS blockers and beta blockers. But elderly hypertension is more volume related actually. So people beyond 60 years of age, diuretics and calcium channel blockers are preferred. And diuretics have had an upswing and downswing. But if you look at the all-hat study, the largest study, chlorothiazide produced greater blood pressure reduction than lisinopril and amlodipine also. So these drugs are there to stay, I would say, and they are effective as add-on drugs. The accomplished trial did tell us that a combination of ACE and a calcium channel blocker is better than ACE and a diuretic. But till that time, we all used to believe that the diuretic should be a second add-on drug if it is not the first drug. Only little caution I would say here is never combine a beta blocker with a diuretic, because the new onset diabetes then becomes an issue. But otherwise, as you rightly said, sir, diuretics in low dosages are very, very beneficial. As today we are treating hypertension, we don't talk of this drug is better than other. We only talk of this combination is better than other combination. That's how we should be. We should be centric towards combinations, and in that sense, diuretics are an excellent.
Thank you, sir. It is often said, and quite correctly so, that better than 1,000 hours of diligent study is one day spent with a great teacher. We had the privilege of having such good teachers with us in the form of Dr. P.C. Manoria sir, Dr. Wander sir, and Dr. Tivaskar sir. It was an absolute delight to have you with us. We'd love to have you with us in all future CMEs. We will all benefit from your expertise. Thank you very much. Thanks are also due to our dynamic chairpersons and moderator, especially Dr. Banik sir, Dr. Puneet Saxena sir, and Dr. D.P. Singh sir, who very smoothly and successfully conducted this CME. We are very thankful and highly obliged, sir. Special thanks are also due to our guests of honor who have been our guardians throughout the inception of IACM, Dr. K.K. Parekh sir, Dr. M.M. Singh sir, and Dr. A.K. Gupta sir. And the CME would not have been successful but for the presence of a large number of participants who were there for the entire 2 hours session. Thank you very much. With this, I would like to thank you all and love to see you again on first Thursday of August. Thank you.
Good night, everybody.
Thank you.
Stay safe,
Good
stay
night.
happy. Thank you for the wonderful opportunity. Thank you.